a series of Cedarcrest webinars. My name is Dr. Dase. I'm a consultant obstetrician and gynecologist. Part of Cedarcrest's mission to contribute our part to developing high quality and highly professional and affordable healthcare system in Nigeria. We are presenting this series of webinars to educate the population about health issues and how they can solve them. So today we will be discussing uterine fibroids treatments without operation, and the speaker for today will be taking on this topic is Dr. Ferdinand Umelo. He's a consultant obstetrician and gynecologist with Cedarcrest Hospital. He's an infertility specialist with extensive training both within and outside the country. He's also the medical director of Cedarcrest Hospital, Gudu, in Abuja. So he will be taking us on this important topic. So it's for those who are, for most people, for women particularly, uterine fibroids are among the commonest gynecological conditions they encounter. And of course, there are always questions regards the condition and treatment. So traditionally in our environment, you have the surgical treatment, which is operation. And commonly patients do ask, are there other forms of treatment? So we are going to know about other forms of treatment or non-surgical or treatment without operation today. So Dr. Ferdinand Umelo will be taking us on this topic.
Good morning, everyone. Welcome to this presentation. Thank you, Dr. Dase, for the brief introduction. I hope everyone can hear me. Thank you, Dr. Dase, for the brief introduction. My name is Dr. Umelo Ferdinand. I'm an obstetrician gynecologist with Cedarcrest Hospital, Abuja. So we will be taking this as our second in a series of presentation webinars to the public. This presentation is basically public friendly, so it's devoid of a lot of medical, all the big stuff you have in medicine. That's for the medical world. We do have two different series of webinars we do. One is targeted at the medical community, where we speak basically to doctors alone and other healthcare workers. Then the other is targeted at the public. So this is one of the series that is targeted at the public, and I've tried to make this presentation as basic, as simple as possible. Dr. Dase, if you can enable me so I can share my screen. Can the host enable me to share my screen, please? So while that is being done, I'll just continue. Uterine fibroid is a very common condition in women. It's something you hear a lot of women talk about the fact that they have this mass, they have this heavy bleed, which worries them. And a lot of people also ask, how does this affect my fertility? Is this going to prevent me from having babies? Am I going to find it difficult having deliveries? Should I get pregnant? So host, please, I'm waiting for you to share your, to enable me to share my screen, please.
You can go ahead and share your screen.
Okay. I don't know, can everyone see my screen? Hello?
Not yet, no.
Not yet, okay. So while that is going on, so we don't keep it, the house silent, we have our experience here in Nigeria in terms of fibroid, and common thing you find around the world when people have fibroid is the fact that they get surgical options of treatment. But this presentation is aimed at letting people know that there are other options which are non-surgical, and that's available here in Nigeria, is available here in Abuja and a few other cities in Nigeria. So that's the introduction I need to make and educate the public so they know what other options. Should I not want a surgery? Am I scared of surgery? Do I want to keep my uterus? How does this affect fertility? What safe options are available for me to do that?
What uterine fibroid? You like it? No.
Just a minute, guys.
Non-surgical intervention, management of fibroid.
I'm still waiting for the host to give me access to share my screen, please. I'm sure we'll sort that out in another 1 to 2 minutes. Thank you for your patience.
Yes, we can see it now.
Okay, so I guess everyone can hear me. So uterine fibroids, as I was trying to say earlier on, didn't know I was on mute, is there are non-cancerous tumors that affect the female genital tract, and they are the commonest non-cancerous tumors in the female genital tract. A lot of other tumors affect the female reproductive system or genital tract system, and those are mainly malignant. But one good thing about fibroid is that they are not malignant, and so they do not actually progress to cancer. That is what I'm trying to say. They do not progress to cancer. A lot of women do live with them from their mid-20s way into menopause, just that it may begin to show signs and symptoms as they get bigger or as the woman gets older. They are usually hormonally linked. So the main hormones that make fibroids to grow are estrogen and progesterone, most especially estrogen. And you know, estrogen and progesterone are the main reproductive hormones that you find in women. So anything that makes estrogen and progesterone hormones to rise in the female body, and when these women have any size of fibroid, it can encourage it to grow. Otherwise, we find out that prepubertal young girls and women who are in menopause, who have a very reduced amount of these hormones, usually do not have their fibroids growing. These tumors affect women mainly in their reproductive years. So you find out that within the ages of 20 up until premenopause around 50, that is when this tumor affects women. It's commoner among Blacks for some very unfortunate reasons. It's commoner among Black than white. So you find 60% of white women having fibroids, and as much as 80% and over of Black women or women of African ancestry will develop fibroid during their lifetime. What is the incidence? How common are uterine fibroids? The true incidence of fibroid is actually uncertain, as many women with these symptoms are asymptomatic. What I'm trying to say here is that a lot of women will have fibroid, of various sizes. So those women who develop fibroid and are very small, or the locations are more on the outside of the uterus compared to the inner lining where there will cause heavy bleeding, these women may go throughout their reproductive life unnoticed, not knowing that they have fibroids. A few of them may have this diagnosis made incidentally when they go to do an ultrasound scan or get examinations, MRIs for some other medical conditions. Up to 25 to 50% or greater of women will present with clinically apparent tumors during their reproductive life. So when the tumor becomes clinically apparent, the size increases to a point where the woman is able to palpate it. She's able to touch it when she examines her abdomen. Also, they may begin to become symptomatic. They are commonest among women in their 30s and in their 40s. So you see less fibroids in women who are in menopause or who are much younger. Of all the women that develop fibroids, 10 to 30% of these are symptomatic. So you still have as much as 60 to 70%, 60 to 80% of women with fibroids not showing any form of symptom, whatever. What are the risk factors? This is something a lot of patients will ask. What will make me develop a fibroid? Why am I at risk? Why should I develop a fibroid? Age is one of the first risk factors I'm going to discuss here. As women get older, they stand a chance of developing uterine fibroid. This is because the level of hormones, estrogen and progesterone, which they have in their system, begins to build up. And as they build up, they causes
when you're crying, you're behaving like a child. That's when you're crying.
So please, everyone should mute their mic so others can follow. If your mic is unmuted, please try and mute it. The age, like I said, as women get older, they stand a risk of getting fibroid. I've talked about the fact that Black women are likely to have fibroid more than the Caucasians. In fact, if you are Black, you stand a 3 to 5% chance of having a fibroid compared to a fellow Caucasian woman. And also Black women with fibroids usually develop it at a much younger age compared to Caucasian women that develop fibroid way late into their 40s. Black women will begin to develop fibroid as early as in their 20s. Now, for Black women, they do have, apart from the fact that they develop fibroids much earlier, they have the propensity to have their fibroids grow bigger. Okay, so we'll find Black women having very huge and big fibroids compared to the whites. We know from experience that here in Africa, or even in the America where you have Black women of African ancestry, those that develop fibroid have it quite big compared to those who are not Blacks. So they have it much earlier, it develops much earlier in life, it gets far much bigger, the symptoms are more, they stand a chance of getting surgeries much earlier compared to their fellow counterparts. Family history for mothers and daughters and sisters, it goes in that line when there's a threefold increase in first degree relatives. So if you are a woman and your mother had fibroid or your sisters have fibroid, the chance that you're going to have fibroid is high, and the chance that your daughters are going to have fibroid is high. However, if this does not exist in your family, then that's most likely not going to happen. That's not saying that if you don't have fibroid in your family, you cannot actually develop fibroid. Early onset of menstruation. Women who begin to menstruate very early tend to have fibroids develop much earlier. This is actually because they get exposed to these hormones, which we call estrogen and progesterone, much earlier. So imagine starting menstruation at the age of 9 or 10. Okay, your body begins to now get exposed to estrogen and progesterone, unlike starting menarche, which is menstruation at the age of 16. Currently in the world, the age at which women attain menstruation, early menstruation, is actually reducing. Years ago, women used to get into menarche, start menstruating at the age of 14, 15, 16. But right now, we see much younger ladies, girls, about the age of 10, 11, okay, starting their menstruation. Women who are overweight actually stand a risk of having fibroids develop. Again, this is to estrogen. So a lot of these things are linked to estrogen. Women who are overweight do have very much high level of estrogen in their system, and should they have a small growth of fibroid, this will just make it grow bigger. Childbirthing. We know from what we've seen, from statistics, from documentation, women who are not able to have children, women who do not give birth for one reason or the other during their reproductive years, tend to develop fibroids. There's this saying that we used to say while we were in medical school that the uterus is such a very jealous organ. Its aim is to carry a baby, which we call a fetus. Its aim is to carry a fetus. However, when the uterus sees that it's not able to carry a fetus, it will instead carry a fibroid. The uterus always wants to carry something. So it's either it's carrying a fetus or it's carrying a fibroid. So childbirthing is protective. Women who have kids, who get pregnant and have babies, tend to have fibroids develop less compared to those who do not have kids. That's one reason why you see women who are, when you talk about infertility, when you study women with infertility issues, a lot of them usually do have fibroids in most of them, not all of them anyway, most of them. Again, another study group which has made this very, very clear is women who are in conventries, the nuns, the reverend sisters. The fibroid rate among that group of people is quite higher compared to their equivalent counterparts who are not, who are actually having babies. So I'll give a brief anatomy of the female reproductive system. Okay, so this, I just want everybody to have this picture in mind. This is the organ we are going to be discussing. This is the female reproductive system. This is the vagina, and all of this is the uterus. The uterus, which people call womb, a lot of women refer to as my womb, my womb, my womb. So that is the womb which people talk about. In the uterus, you have the part which we call the cervix. For those of you who have heard about the term cervix, we have the part we call the cervix, and you have other parts of the uterus. Okay, so this is where the fibroids usually will develop. So that's a brief anatomy. How are fibroids classified? There are different types of fibroids. So you get a scan or you hear people who have fibroids and they say, oh, the doctor says my fibroid is this or my fibroid is that. There are basically different ways we classify fibroid, but those classifications are based on where the fibroids are located, okay? So if I go back to the brief anatomy, and I'm talking about the uterus again, if you notice, the uterus has the inner lining, the inner part of the uterus, which is called the endometrium. So this is the inner lining of the uterus. So any fibroid that begins to grow, any fibroid that grows towards this side of the uterus, towards the inner part of the uterus, has a name. Any fibroid that grows towards the outer part of the uterus has a name. And any fibroid that grows within the muscle, so you see this is the muscle, all of these are the muscles of the uterus, it has a name. So I'll take you back to the classification. So submucous fibroids. Submucous fibroids are usually the kind of fibroids that grow towards the inner lining of the womb. So they grow towards this inner lining. This is the inner lining of the womb. So any fibroid that grows towards this inner lining of the womb is called a submucous fibroid. Any fibroid that grows towards this outer lining of the womb of the uterus is called a subserous fibroid. If the fibroid remains inside of this tissue, which is the uterine muscle, it's called an intramural fibroid. So those are the kind of fibroids I've tried to describe here, the submucosal, the intramural, and the subserosal. Now, the submucosal fibroids are less common in women. They grow towards the inner lining of the womb, but they are the most problematic in terms of their ability to make the woman bleed. So you see women who have fibroids, they bleed for 2 weeks, they bleed for 3 weeks, they bleed with heavy blood clots. They use a pad, they use 5 pads a day, they finish a full pack of pad a day. These are the groups of fibroid that are notorious for that kind of bleeding, okay? Now the size of this fibroid may be very small. It might be 2 cm, it might be 3 cm, it might be 5 cm. So the size actually does not really matter as long as there's a fibroid irritating or encroaching on the inner lining of the womb. It will make the woman bleed very heavy. Usually these other types of fibroid, the intramural fibroid and the subserosal fibroid, are the commonest fibroids you find in women. They usually do not cause a lot of bleeding. They can grow so big, they can grow so massive, but they do not cause a lot of bleeding. Most especially the subserosal kind of fibroids do not have the ability to make the woman bleed. So you find women who have very huge fibroids. You see them, you think they're like 8 months pregnant, and they tell you, I bleed for just 3-4 days. And you find another woman who says, I've done a scan, the doctor says the fibroid is quite small, but I'm bleeding for like 2-3 weeks nonstop. So the one thing we should all understand is that the size of the mass actually does not always relate to the symptom that the patient presents with. You have very small fibroids that are very disturbing, and you have women with very big fibroids who actually their main problem is just the mass effect, and they do not have that bleeding effect. The other type of fibroid I'm going to talk about are the cervical fibroids. So the cervical fibroids usually are located somewhere around the cervix, okay? So they are located around here. So those are the cervical fibroids. There are other classifications which, for the purpose of this discussion, which is aimed at the making a lot of the public, targeted at the public. I'm not going to bore you with a lot of other types like the interligamentary fibroid and the parasitic fibroid. So we'll just stick to these ones, which are the commonest ones that people will have. So this is what I was trying to describe earlier on. This is a fundal subserosal, growing quite big. This kind of fibroid can grow up, fill up the whole abdomen because it is not encroaching on this inner lining of the uterus. Okay, the woman is going to be fine, she may not bleed. And these are the intramural, you can see, this is the submucosal I talked about, which is actually affecting the endometrium. This is subserosal. Okay, so these are the various types. This is a pedunculated submucosal fibroid. Okay, I actually skipped this one, but it's a type of fibroid you can also have. It's like a polyp, it's like a peduncle, it's growing and dangling inside the inner lining of the womb. This again is another reason why women can bleed very heavy, okay, when this kind of fibroid does exist. So I just give two pictures. On here, you see this is a normal uterus. So this is how a uterus looks when we do a laparoscopy. Okay, you see it's just fine, smooth outline. And if on the other side, you see this same uterus distorted by very big masses. So these are fibroid masses. It completely distorts the shape, the anatomy of the uterus. And all of this will begin to produce various kinds of symptoms, which we will talk as we go along. Suffice me to say that the size of the uterus, non-pregnant uterus, is usually the size of a mouse. So for those of you who have a computer mouse, it's just about that size on the average, so not so big. So imagine getting a fibroid as big as this. And this is a picture of a lady who has a very big, huge fibroid. This is, you see this woman, you think that she's about to have a baby, but all of this is not pregnancy. This is a huge fibroid. This lady has probably neglected the fibroid for a very long time, maybe probably scared of surgery, has heard a lot of things, and she's kept this mass, and she's having a lot of symptoms. She had a lot of symptoms from this mass. Let's continue. Degenerative changes. Now, fibroids can undergo some changes. I talked about two here, okay, red degeneration and the sarcomatous degeneration. A few others I will not bore you with, but just for note purposes, there are a few other changes like that. Now, the red degeneration occurs mostly during pregnancy. So when women are pregnant and they have fibroid, they can suffer what we call red degeneration. They have pain, very severe pain, that gets them admitted in the hospital. A few of them may not even know previously that they had fibroids. That may be the first time they are told that they have fibroids when they get pregnant and they come to the hospital with that severe pain, usually in the first trimester, but occur in other trimesters too. They get admitted and this diagnosis is made, red degeneration of a uterine fibroid. And that's actually the first time they get to know. A few others may know previously that they had fibroid, but when women are pregnant, this is the commonest complication that they can have from fibroids. Then also sarcomatous changes. These are cancerous changes. Very rarely do you have fibroids becoming cancerous. If you recall from the beginning of the lecture, I said fibroids are benign tumors. They are not usually cancerous, but in very rare occasions, you have them undergoing cancerous changes. That's not the normal. Hardly you see women who have this, but it's been documented. Clinical manifestation, what symptoms will I have if I'm experiencing fibroid? If I have fibroid, majority of patients who have fibroid will not have symptoms. Majority of patients who have fibroids, their fibroids are usually diagnosed incidentally. So they just go for an MRI or go for an ultrasound scan for one thing or the other, and the doctor says, oh, madam, you have a little fibroid. I'm just informing you so that you note this. For such women, many of them, their fibroids may not grow. But by the time you diagnose of a fibroid, it's good for you to at least once in a while, every periodically take a scan and see and ensure that the fibroids are not growing. When symptoms present, when there are symptoms, what are those symptoms like? Menstrual problems. So the two commonest symptoms that women who have fibroids will present with are menstrual problems and abdominal swelling. Those are the two commonest symptoms that they'll present with. The menstrual problem occurs in 30 to 50% of women. Okay, so if you notice, I said earlier on that the type of fibroids that usually are notorious for menstrual problems are the ones that encroach in the inner lining, which are the submucosal, okay, types of fibroids. So they usually will present with heavy menstrual bleeding. A few other women who do not have heavy menstrual bleeding will have prolonged menstrual bleeding. You bleed for 3 to 5 days usually, but you find yourself now bleeding for 8 days, for 10 days, for 11 days. May still be this flow may not be quite heavy, but you find out that the duration is actually prolonged. It continues like that until you find that the bleeding becomes actually heavy. A few women may have themselves rushed to the hospital because they have fainted, because they have syncopal attacks, because they are feeling dizzy. That blood loss, that heavy blood loss makes them become anemic. So they get to the hospital, they take a blood test, and they find that their blood volume, their hematocrit level is quite low. They get 2-3 units of blood transfusion, they go home, they are fine for a few months, and they start bleeding again. So that repeated cycle of heavy menstrual bleeding, that repeated cycle of having to get blood transfusion affects the woman's quality of life. She's not able to go out, she's not able to have a good social space. She's running home, she's changing a pad. All of this will definitely affect her quality of life. Other forms of menstrual problems that may occur are irregular menstrual bleeding, then painful menstruation. Women who do have fibroids will complain that they have dysmenorrhea. They have very painful menstruation. Abdominal mass, I talked about, is the second commonest symptom that women will have. Now, for abdominal mass, the fact that the fibroid is not, you can't touch it, you can't palpate it when you press your abdomen, does not mean that it will not have it will not be symptomatic. You may still have a very small fibroid. The uterus, which is a pelvic organ, still remains within the pelvic space, but the woman is symptomatic. However, when the fibroid begins to grow into the abdominal cavity, it begins to lose that location where it should be, which is within the pelvic. It becomes an abdominal mass. Then it begins to show. A few women begin to have, when they touch their tummy, they feel something. I've seen a lot of women who come to me and say, well, I've had this mass here, but I actually thought that I was having a big tummy. I never really understood what it is. It's always good when at any point in time you find that you're having some fullness, some suprapubic fullness just below your umbilicus, you're having some unusual fullness, please take a scan. You may have a fibroid growing. A lot of women will not know that they're having a mass until it gets to a point where they get to get a scan and they are surprised that, wow, I never knew this was there all the while. So abdominal mass is actually the second commonest complications or symptoms that women will have when they have fibroids. What are other symptoms? Other symptoms are acute and chronic abdominal pelvic pain. So some women will have constant abdominal pain, chronic lower abdominal pain. Some people do have what we call pelvic pressure symptoms, okay, because you have that growth, you have a mass occupying the whole of your pelvis. There are other organs within the pelvis, which are the bladder, which are the rectum. So I've put this little picture here. This is a fibroid mass that is growing. So it's going to grow into the abdomen and it's going to protrude the anterior abdominal wall. So the woman is going to see a mass growing. This is also a fibroid compressing on the bladder, okay? So the woman is going to have symptoms when there is this compression. This is also a fibroid compressing on the rectum where you have your poo, where you have the feces coming from. She's going to have symptoms from that pressure. So other symptoms that can occur apart from acute and that are associated to the pelvic pressure symptoms will include frequent urination. The woman is going to pee more frequently. This is because the fibroid is compressing on the bladder. Now, for a few women, you have the size of the fibroid big enough to compress the channel that brings urine from the kidneys into the bladder. When the channels, which are called the ureters, are compressed, they begin to pull fluid, and they pull fluid upwards. Those fluids are supposed to go to the bladder. They're not going to the bladder. Instead, it's like you have a clogged pipe that is not emptying, and the up of it becomes very tortuous, very big, and swollen. Now, this constant swelling that you have of the ureters is what we refer to as hydroureters. It can go up to the kidneys and affect the kidneys. It keeps the kidneys constantly wet. So the kidneys are supposed to form urine and empty them per second at every minute. But the kidneys remain constantly wet because there's a blockage downstairs and the urine is not going to the bladder. Other symptoms which can also occur include chronic constipation. So I've just talked about bladder infection, kidney infection, chronic constipation, severe cramping pain. It can also lead to varicose veins, where you have dilated veins on the lower limbs. This is because the venous complex down here in the pelvis has already been compromised. Instead of the veins carrying blood back to the heart from the lower limbs, they are blocked somewhere still. So you have blood pooling on the lower limbs, and eventually it could lead to a deep vein thrombosis, where you have blood clotting down the legs. I choose to put this here so that we understand how fibroid affects infertility. A lot of women say, if I have a fibroid, I can get pregnant. That's actually not so correct. Fibroid and pregnancy remains controversial. There are a lot of women we see who come to the clinic, they are pregnant and they have fibroid. There are a lot of women who go ahead to have successful pregnancies, successful deliveries, and they have fibroid. So fibroid per se do not actually cause infertility. When fibroid coexists with an ongoing pregnancy, however, it may lead to challenges during the course of the pregnancy. From the first trimester, there's risk of miscarriages, there are risk of I've talked about the regeneration. The woman is in and out of the hospital. There's a risk of miscarriage. There's a risk of preterm delivery. And there are also risks associated with delivery when the woman is 10, when she's in her third trimester. Most of these women you find will have their babies through a C-section. And for those women who develop a cervical fibroid, where this fibroid is located in the cervix, it can actually block the cervix, which should dilate and allow that baby come out from the vagina through a vaginal delivery. And you find them having a C-section. When fibroids are associated with infertility, how does that relationship work? I will take you through that relationship. Now, the size of the fibroid are actually something that's very important that we'll look at. Now, the size of the fibroid, if you have very big fibroid, like the lady I showed you, the picture I showed you earlier on, or the earlier picture I showed you concerning the uterus, it can actually completely distort the womb completely. So if it distorts the womb completely, you find out that you have very big fibroids that are capable of blocking the tubes. The tubes, the fallopian tubes, are what takes the eggs from the ovaries after an ovulation into the womb itself so that they can implant when there's a fertilization. The fallopian tubes are also the conduit that enable sperm, when deposited, to climb up into the uterus and swim through the tubes to meet the eggs. Now, when you have big fibroids that block those tubes, you find out that the egg and the sperm cannot communicate. And that, again, can affect fertility. When you have fibroids that implant in the inner lining of the womb, that grow in the inner lining of the womb, the submucous fibroid we talked about, it could actually lead to implantation problem. So a few women may find it difficult. They may get pregnant, but those pregnancies will not implant. Then overall, it can cause endometrial hostility. So those are some of the theories that have been deduced as to how fibroids actually cause infertility. A few women who end up getting surgeries for very big fibroids may find out that as soon as you take out those big fibroids, the tubes become open again, or you take out those endometrial fibroids encroaching on the inner lining, which are the submucosal fibroids, that hostility goes away. And those women are able to achieve a pregnancy. So examination, when you go to the hospital and you get examined, you find that this is probably what you get if you have a big fibroid. For those who do not have a big fibroid, the doctor should still be able to at least assess and see that you have a fibroid. If you get an examination and the doctor is not picking any mass from the abdomen, a scan will help. And once a scan is done, the doctor should be able to see if you have a fibroid or not. Usually fibroids will feel firm. They're usually hard. So once you touch your abdomen, they're usually hard. And you notice that, man, there's something growing in here, definitely. How is the diagnosis made? Diagnosis basically from history and examination. Once the patient sits with the doctor and tells the doctor, this is what is happening to me, and the doctor examines the patient, the doctor should be able to make a diagnosis, at least to a large extent. But for those cases where there's some difficulty with arriving at the diagnosis, an ultrasound and an MRI are actually the gold standard that can help. Blood and urine investigations will also be done for you. The doctor is interested in knowing whether the patient is anemic for those who bleed very heavy. The doctor is also interested in knowing if the kidneys are functioning well, because when you have hydroureters, you have hydronephrosis developing, that can actually affect the function of the kidneys. Treatment. So this is about the meat of the matter for today. There are various kinds of treatments that are offered to women that have uterine fibroids. Okay. Now, when we consider treatment for a patient, we consider the age of the patient. We're interested in the parity. By parity, I mean, is this woman Does she have children? Does she not yet have children? We're interested in her fertility wishes. Is she wishing to have children? Is she not wishing to have kids? Okay, all of these are things we put together, and we also consider the size of the fibroid. We consider the location of the fibroid to be able to arrive at a proper plan for the patient. There are various forms of treatment: expectant, conservative, up until the interventional or non-surgical. For expectant conservative, these are usually what we do for women who have small fibroids, diagnosed incidentally. They do not have any symptoms. We just reassure them, tell them to go, watch and wait, take scans periodically, assess whether your fibroids are growing. For women who are close to menopause, women who are 40 and above, and we are picking fibroids of 4 cm, 5 cm that are not quite big, not symptomatic, we just reassure them and leave them. We don't do anything for them. So it's not all fibroids that actually gets treated. Some will just we just wait and we watch. Now for some fibroids that usually will need treatment, yeah, forms of treatment will include medical. These are the use of medications. If you noted here, I said they do not actually eradicate fibroids. A lot of supplements, a lot of medications you find out there. There are a lot of myths out there. Take this, take that, use this, it will make your fibroid to dissolve, to make your fibroid to melt. You see women who waste money for years, who waste hundreds of thousands, buying all forms of supplements, all in a bid to make their fibroid disappear. And at the time you see them again in like 5-6 years, they have a very big fibroids and they say, oh, had I known, I would have done this surgery much, I would have had a treatment much earlier before it got this big. So the take home point here is that medical medications do not eradicate fibroids. They can ameliorate the symptoms, they can reduce the size transiently, but they do not take them away. The day those medications are discontinued, those fibroids will continue to grow again. A few of these medications actually will make the women feel like they're in menopause. So these are commonly when we use the injectables. The injections we call the gonadotropins. We use them to try to shrink the fibroids a bit. And those injections, usually, what do? They knock off the estrogen and progesterone supply. They knock off a few of these reproductive hormones, and the woman feels she's in menopause. So when you inject this kind of injections or medications for women when they are not yet close to menopause, they begin to have a lot of those hot flushes, etc., that you have for women who are in menopause. Surgical treatment are myomectomies and hysterectomies. This is what a lot of women are scared of. I don't want to have a surgery. I don't want to have a surgery. A myomectomy is actually a form of surgery where the fibroids are just taken out and the uterus is left in place. And a hysterectomy is a form of surgery where the whole of the womb is completely taken out. Hysterectomies are usually reserved for women who have completed family size, women who are in menopause, women who actually probably do not wish to have kids anymore. So you could completely take out their uterus and that gives a complete cure for the fibroid. However, when you do a myomectomy, you're preserving the uterus and such women can still go ahead to have children. The bone of my discussion today is interventional non-surgical. So there are available forms of interventional non-surgical options of treatment, which include uterine fibroid embolization and what we call HIFU, high intensity focused ultrasound myolysis. I'm not going to be talking about HIFU today. We'll discuss HIFU in one of our next series, but today I'm going to be talking about uterine fibroid embolization, okay, which is a non-surgical, non-operative treatment for uterine fibroid. It's a form of treatment that is available for all women who wish to have fibroid treated without having to have an operation. Uterine fibroid embolization is also called uterine artery embolization. The term uterine artery embolization is more actually used right now because it's that procedure can also be used to treat other forms of diseases that occur in the body. So permit me to just stick to the term uterine fibroid embolization. Now, it's usually a day procedure. Patient comes in, gets the surgery, quick lasts about 1 to 1.5 hours, and patients can go home that day. However, we keep our patients overnight just to be sure they are fine. The following day, patients are fine to go home. It's usually performed in an angiography suite. An angiography suite is popularly called a cath lab, a cardiac catheterization suite, okay? And that's where you get a cardiac, fibroid embolization done, okay? And angiography suites are few in town, like here in Abuja where we stay, there are just about 3 angiography suites in town. You have a few in other places of the country. So it's an image-guided procedure, and the fibroids are approached using real-time X-ray guidance into the uterine arteries. I will show you a picture of what I mean, and I'll explain more once we get there. The patient is conscious and not sedated during the treatment. There is no general anesthesia, there is no spinal anesthesia. Patient is conscious, but just to make the patient relax, we sedate the patient a bit so that they are a bit relaxed during the course of the procedure. Usually what happens is that there are particles that we call embolization particles. Okay, these are injected into the artery supplying the uterus and the specific fibroids, cutting off the blood supply. So once we cut out the blood supply to the fibroids, specific fibroids, we do not cut out the blood supply to the whole of the uterus. We target the fibroids, we cut out the blood supply to the fibroids, and the fibroids usually will begin to shrink over time. I will discuss this further as we go ahead. This is an angiography suite. This is what we have here in Cedarcrest Hospitals, Abuja. It's actually a GE Optima IGS 330 machine. A few of them you find in the country. I don't think there are more than 2 or 3 currently in the country. So this is where we do our fibroid embolization. This suite is also where we have other procedures like the cardiac pacemakers, angiography, angiogram, valvular repairs, etc. being done. Okay, so this is a multi-purpose angiography suite. And this is a uterine fibroid embolization procedure ongoing in the angiography suite. Who is the ideal candidate for uterine fibroid embolization? You may want to know. Premenopausal women with symptomatic intramural, submucous, and subserous fibroids. I have taken out some fibroids like the pedunculated fibroids, which may not be treatable when you do an embolization. But women who have the forms of, and the cervical fibroid, which I didn't put here, I've described earlier on, are ideal candidates for uterine fibroid embolization. Women who are not viable surgical candidates, there are a few women who will not suit surgery. Okay, these are the kind of women you want to do. Women who come in severely anemic, you won't want to take them into theater because they may lose blood. They will lose blood from an open surgery. There are candidates who an embolization will suit. Women who are candidates for hysterectomy or myomectomy but want to avoid surgery completely. All those women who have strong aversion for surgery, okay? Fibroid embolization is something you should opt for. Women who want to retain their uterus. Here in Africa, you find a lot of women saying, no, I don't want to retain my uterus. I don't want to lose my uterus. I want my uterus to stay. I don't want anything to happen to it, for one traditional belief or the other. But this fibroid embolization keeps your uterus in place. Women who want to reduce time away from, who do not want to reduce time away from work and family. Women who do not want to reduce time away from work. If you take a hysterectomy or myomectomy, it will take you up to 6 weeks. Okay, sometimes 3 months to get fully recuperated. But if you do an embolization, within 7 to 10 days, max 2 weeks, patient is back, patient is feeling herself again. Women, then I'm going to talk about technical challenging cases. Patients who say, no, I can't take a blood transfusion, because usually no doctor will take you in to have a myomectomy or hysterectomy without making blood available for transfusion should the need arise. Okay, so women who refuse blood transfusion, or women who have had multiple prior surgeries. There are a few women who have had a lot of multiple fibroid surgeries up to the point where they develop what we call a frozen pelvis. The doctor is not able to proceed even if he enters that abdomen. He's not going to be able to assess those masses. There's risk of bladder injury, there's risk of bowel injury, there are risk of contiguous injuries to all of the surrounding organs and tissues because they have developed a frozen pelvis. These women are ideal candidates for uterine fibroid embolization. So this is what a uterine fibroid embolization procedure looks like. Okay, so I'll take you back here. The fibroids are usually approached through the femoral artery, just by the groin area. In recent times, we're able to approach the fibroids through the radial artery, so by the wrist. So we can actually enter the blood vessels through the wrist, one of the arteries on the wrist, or we enter through one of the arteries, femoral artery, by the waist region, the groin. So it is just a puncture, like you're getting a line, you want to get a sample collected in the hospital, or you're not feeling fine, you need to take some fluid, you need to put a cannula in. Something as basic as that is what we do here. So once we do that and we get in, these are small catheters. They're very fine catheters that we use to trace down to where you have the uterus and where you have the uterine arteries, and we're able to go. So on this other side, you find that this is our catheter coming in, and we're not targeting the whole of the uterine artery. We're targeting these very minute tributaries these very minute branches of vessels that supply the fibroid. These are the vessels we block completely. Once we do this, we inject those embolization particles. The embolization particles are small. They are like foam. Okay, they are like soft. They dissolve and they swell up and they block up all of these vessels. They are safe in the body. They do not cause any problem. They remain there for years. These vessels, like I said, gets blocked and these fibroids will begin to shrink. So this is actually a pre-treatment, this is actually a pre-treatment fibroid. And once we treat, we monitor these patients, get them to do MRIs at 6 months and at 12 months, 1 year after, and we monitor the progress, gradual reduction or shrinking of this fibroid mass. This procedure is actually very unique in the sense that the moment these patients get this procedure, those who bleed heavy, over 80–90% of them will stop bleeding heavy the moment they have this procedure done. The next menstrual bleed they have, they usually call in to say, doctor, I think I've had a life change. I think I'm fine now. My bleeding has stopped. So what will now be left is for us to just monitor the fibroid mass and see them reduce and shrink over time. So this is what happens usually when you have pre-embolization with all the big masses everywhere in the abdomen. And this is what happens when they begin to shrink away. Okay, so this is before a UFE and this is after a uterine fibroid embolization. This is a real life picture of a patient who had an MRI. Okay, and this is the fibroid mass before patient had an embolization. And at 6 months post-embolization, you see all of those big fibroid masses already shrinking away. This is just at 6 months. By the time this patient got a one year MRI, this uterus had completely reduced to almost its ideal level. And this is a lady again who had fibroid embolization, and this is a 6 months post-embolization picture. Now, what are the advantages of fibroid embolization? It treats all fibroids simultaneously. Okay, it's minimally invasive. Complications are infrequent. Recurrence of treated fibroid is quite rare. I need to speak about recurrence of treated fibroid. The only thing that cures fibroid, the only treatment that cures fibroid is a hysterectomy. That is the only thing that makes fibroid not to grow back. That is when you take out the uterus. Any other form of treatment, you can have the fibroids grow back. But with fibroid embolization, it is rare. Even women who do myomectomies, a few of them will call back and say, I've seen a few women who say, oh, I had a surgery and my fibroids are coming back. Yes, that's a possibility. So your doctors will always let you know that myomectomy is actually not a complete cure. The fibroids can grow back. However, if the fibroids will grow back, they'll take about 5 to 7 years on the average to grow back for majority of women. A few women who have their fibroids growing sporadically, they'll have them grow back within 2 to 3 years. But what we have seen is that for majority of women, within 5 to 7 years, their fibroids can grow back. But that's something that's not so common when you do a fibroid embolization. There's shorter recovery period. There are no adhesions or scars formation. This usually happens when you have an open surgery. You have scars being formed. There are no adhesions or scar formation when you have a fibroid embolization. Minimal blood loss, little or no blood loss. There's no need for transfusion. There's no need for general anesthesia. Surgical incision is avoided, so the woman does not live with a very big, unpleasant scar on her abdomen. Emotional, physical, sexual advantages of retaining the uterus. And there is immediate reduction in the volume of blood loss, pain and pressure, and marked reduction in the fibroid volume over 6 to 12 months. What are the disadvantages? I'm sure a lot of you will ask, what are the disadvantages? 10 to 15% of patients do not respond to this treatment, okay, despite technical success. So we treat, and you find out that a few patients will not respond. So in effect, it means that the success rate is about 85 to 90% for this kind of surgery procedure. Pelvic pain or cramping will occur after the procedure for a few days. This usually will last for a few days. There is usually some internal heat. Some women say, I feel hot. That's usually because the fibroids are shrinking, the fibroids are dying away. All of that will cause some pain and cramping. There are 1 to 2% chance of serious complications, which will actually result to hysterectomy. So a few patients may actually end up in a hysterectomy, but that actually do not occur. Now, for these women who will end up with hysterectomy, they are usually women who have very huge, like the very first picture I showed you, very huge, massive uterine fibroids, the ones you see and you think they're like like 10 months pregnant, if anything like that exists. So those kind of patients, if you embolize them, they may actually develop what we call an infection and may end up with a hysterectomy. So patient selection, proper patient selection matters a lot. A few patients may have the fibroids slough off into the endometrial cavity for those endometrial kind of fibroid, and it can expel from the vagina. That has been reported. And then patients over 48 years may have potential for ovarian dysfunction. So once you do this, you find out that a few of these women may begin to complain of menopausal symptoms. And what to expect afterwards, like I said, mild cramping, pelvic pain, nausea, vomiting are common. There's some vaginal discharge, which is common for some people, low-grade fever and fatigue. However, most women resume light activities in a few days and return to work in 7 to 10 days. Approximately 90% of women are satisfied from the procedure and require no further treatment for their fibroid. How well does it work? I talked about this earlier on. Bleeding-related symptoms are resolved significantly in over 90% of patients that have heavy menstrual bleed. This is taken care of immediately. Then the mass-related symptoms resolve or are significantly improved in 85% of patients over at least 6 months. Recurrence requiring repeated uterine fibroid embolization is rare. Less than 5% do we need documented cases of having need to go back for a repeat fibroid embolization. What do we do for follow-up? Patients are seen periodically 1 to 2 weeks, 4 weeks, 6 months, and then 1 year. At this time, we do an MRI at 6 months and 1 year to assess the effect of the procedure and measure the fibroids and see how well they are doing. I take this as a common question. Will I retain my fertility after I do an embolization? There are dozens of reported healthy pregnancies that have occurred when women do fibroid embolization. You look up the literatures, the internet is there, a lot of documents are there for you to read up. I just don't want to bore you, like I said, but there are dozens of reported pregnancies that have occurred after fibroid embolization all over the world. When women do fibroid embolization and they still find it difficult to get pregnant, it is always good to know if there are other causes of that difficulty with getting pregnant. For example, before women get a fibroid embolization, for those who are in their reproductive age group, we usually will like to do a full fertility assessment for them. Hormonal issues can be responsible for women not getting pregnant. Tubal blockage can be responsible for women not getting pregnant. So all of this will need to be looked at so the patient is sure. If women get an embolization and they still cannot get pregnant, it will be good to look again and say, what else is responsible for this? If infertility is due to fibroid, fertility may improve in selected patients after uterine fibroid embolization. I'm coming to the end of my presentation. What are the take-home points? Fibroid are common problems and often cause significant pain and suffering in many women. There are various treatment options available, which we've talked about. It is good for you to know all your symptoms before you take a decision. And every physician that treats you, regardless of the disease process, should inform you of all the kinds of treatment available for fibroid so that you make an informed decision. A few people may not, because the fact that they don't have the capacity to perform all of these newer modern options, which are non-invasive, which are non-operative. They just tell you about a myomectomy, they just tell you about a hysterectomy. Please always inquire, are there other forms that I can benefit from? And let these people refer you to the appropriate persons who are capable to carry out all of those procedures. Finally, uterine fibroid is safe and effective alternative to more invasive surgeries for treatment of fibroids and related symptoms. Thank you very much. I hope you enjoyed my presentation.
Thank you, Dr. Melo, for this beautiful presentation. Dr. Melo, you can stop your screen share now. Dr. Melo? Dr. Melo? Dr. Melo, can you hear me? can stop your screen share now. Stop screen. Dr. Melo, please stop sharing your screen. Okay. Oh, he has been talking now. Okay.
That's for me. It should be on top. That's to unmute. No, just click here. Just click that's to unmute. Just go to this.
Okay, Dr. Dasse, I will stop. I'll do that right away.
Okay. Okay.
Okay, thank you. That's done.
So thank you, Dr. Melo, for this wonderful presentation. We thank the audience for joining us today. Like I said, uterine fibroid is a very topical issue, and we know our participants and audience have lots of questions to ask. So all those that have questions, some of you can type in the question in the chat box, or you can raise your hands and we'll enable you to ask questions. So we'll take a few questions at a time, maybe like a batch of 5 questions, and then a batch of 5 questions, then Dr. Melo will answer those questions and we'll take another batch. So I'll start allowing Precious to ask questions first. Yeah, Precious?
Yes, I can hear you.
Yeah, you can go ahead with the question.
Good morning, Dr. Thank you very much, Dr. I want to know if...
Please, Precious, can you speak up?
Yes, I can.
Yes, much clearer now, better.
Okay. I say thank you very much, Dr. Darcy. Thank you very much, Dr. Bello, for that beautiful presentation. Then I have 2 questions. One is, does fertility treatment or drugs actually make fibroids grow? Because me, as a case scenario, I am battling with secondary fertility, and there was no diagnosis of fibroid because I've done series of scans before now. But the moment I started taking fertility treatment, and I think it's scan and fibroid.
So the questions in the chat.
Although it's small, 2.9 thereabouts posteriorly. Or I want to know if fertility drug can actually result to fibroids. Actually cause fibroids to develop. And secondly, what is the cost of the what Dr. Melo talked about after? I don't know if you got that.
Dr. Melo, okay. Dr. Melo, did you get her question? Hello, Dr. Melo. I muted him before. I should just unmute all.
You can just take this in there.
Dr. Melo, please. Muted. Dr. Melo. I can't hear you. You're unmuted here. Maybe you need to unmute yourself from your. No.
Hello.
Yes.
I'm audible, I guess.
Yes, you are. Sorry, everyone, for the technical glitches. So, Dr. Melo is back. I was asking if you heard Precious's question.
Yes, I listened to Precious's question. Yes, I did.
Let's take some more questions, then you answer them together.
Okay, that's fine. Please go ahead.
Okay. Amadi, please go ahead.
For your presentation.
There's a lot of echo from your side, Amadi. There's a lot of echo. We can hardly hear you. Maybe you can type in your question.
Can you please type in your question? There's too much echo, so we could barely hear you. So, Edosa, can you ask your question, please?
I want to say well done for that fine presentation, Dr. Melo. The way and manner you went through it. My question is not just question, I just want to find out, because many out there, they are so concerned, this procedure, how much will it cost? How much will it cost? I want to know the cost and effect of it. That is my question. Thank you.
Okay. Thank you, Edosa.
We can take more questions, Dr.
Yes.
So,
more questions? Okay, we also have some questions on the chat box. Okay. So someone asked, Dr. Melo too, someone asked whether UAE can be done for multiple tiny fibroids as small as 3 cm in size. That's from Chinwe. You got that?
Yes, I did. Why are you going through? Why are you going through that? Can I just answer the first?
Yeah, no, I want to have a pool of like 3, 4, then you answer them at once.
Okay, please go ahead.
Then one more from Titilayo, but asking whether virgins or sexually inactive people could get fibroids, or fibroids are common in sexually inactive women or virgins. So can you answer those questions? I will take more.
Okay, so let me just start with the last one. I think Titi was asking if virgins and people who are not sexually active can have fibroids. The answer is yes. The answer is yes. In fact, there are people who do not have children, who are not betting, actually stand a higher risk of having fibroids. So it doesn't have to do with having sex anyway, having intercourse. It doesn't have to do with having intercourse. It has to do with the fact that the woman keeps getting exposed to estrogen continuously. Okay, you see, birthing is a process. The period where the woman carries her pregnancy is a process where there is an alteration in the woman's hormonal level. Okay, and that actually confers some protection. However, when there is constant exposure to estrogen and progesterone for a very long time, that can actually predispose the woman. So yes, you can have fibroids, even though you're not sexually active, you can have fibroids. Can uterine artery embolization be used to treat very tiny fibroids? If you listen to my presentation closely, I said fibroids that are small and that are not symptomatic, they do not require any form of treatment. That is the truth. Patients are reassured and they are left go. They are small and not symptomatic. But if the fibroids are symptomatic, 3 centimeter submucosal fibroids that is causing the woman to bleed like for 2 weeks, for 1 week, she should have treatment. And yes, fibroid embolization can be used to treat that fibroid. The first question was if fertility drugs actually, causes fibroid to grow. The truth is that a lot of those fertility drugs that we use actually contain estrogen, okay? Most of that, at one point in time during a course of fertility treatment, doctors will put you on estrogen, okay? So yes, exposing yourself to estrogen from the outside, okay? Exogenous estrogen can actually make your fibroids to grow. I didn't talk about combined oral contraceptive pills during my presentation because there seemed to be a bit of some controversy, but studies have actually said that women who use combined oral contraceptive pills, these are daily pills, daily pills for preventing pregnancy that women take 21 days in a month. They contain both estrogen and progesterone. Some studies have documented that women who use daily combined oral contraceptive pills for a very long time actually stand the risk of having developing fibroids later in life. So yes, using fertility drugs can expose you if you are exposed to exogenous estrogens for a very long time. I'm going to talk about the cost. I see a lot of people asking for the cost of fibroid embolization. Dr. Darcy, I don't know if you have any other questions.
Yes. Okay, someone, Amy asked so she has a very large fibroid and many small ones. So can uterine fibroid embolization work for her? Also had Gloria asking the same question you just answered, whether birth control pills or birth control methods create enabling environment for fibroids. So then the costs, then several people are also asking for the costs. Yeah.
Okay. Very large fibroids and some small ones. Yes, fibroid embolization is ideal. You're actually a candidate for a fibroid embolization. It can treat your fibroid. That is not a problem. We actually, however, need to know and be sure that these are actually not like pedunculated fibroids, or these are not like very intramural pedunculated fibroids, or submucosal endometrial pedunculated fibroid. Otherwise, yes, fibroid embolization can treat. Birth control, then generally, no. Birth control, you see, I picked combined oral contraceptive pills I talked about. Usually birth controls that are mainly progesterone based usually will not make your fibroids to grow. A lot of the birth controls you have currently are mainly progesterone based, something like the Implanols and the Mirenas and all of those. They do not contain estrogen, so they will not actually cause your fibroid to grow. But I specifically talked about the combined oral contraceptive pills. For cost, a lot of people are asking for cost. The cost will range between 1.8 and 2.2 million. Okay, 1.8 and 2.2 million. That's the average it will go for, and that will take care of everything that you need to do. I hope I've answered that question on cost. I'm just trying to scroll to see if I have any other questions, but participants can ask questions. I'm still available.
Also, there's a question from Dr. Victor. So what's the time frame for shrinkage for very large or for giant myoma? How long will it take to shrink following uterine fibroid embolization? Also, there's another question from Dami. Since I have about 4 different fibroids, the biggest is about 5.5 cm. What's the best treatment?
Time to shrink. Time to shrink. Like it depends on how big the fibroid is before embolization. Fibroids that are not so big usually will shrink much faster than fibroids that are so big. It's a bit difficult for me to begin to give an average, a time frame, but from our experience, most patients will have at much as 70-80% reduction within the first year. Okay, within the first 6 months, a lot of patients will have over 40 to 60% reduction. And within 1 year, 6 months later, most people will achieve at most 80% reduction. So what is left for the reduction to occur over time? But other symptoms like the bleeding, effect on the bladder, effect on the kidneys, the chronic constipation, varicose veins, all of those things will disappear usually within the first 1 to 3 months. Best treatment for 5.5 cm fibroid and a few others. I will again emphasize that I'm trying to just scroll to that question. I have about 4 different fibroids. The biggest is 5.5 cm. I'm sure you meant to say 5.5 cm, not 5.5 meters. Again, there are women who have 5.5 centimeter fibroids and are not symptomatic, and they are free to fly like a bird. We usually will not bother them. If it is symptomatic, you will require a treatment. You should have the various forms of treatment discussed with your doctor, but an embolization is actually more ideal for you because you won't want to get a scar for just to take out a 5 centimeter fibroid. I'm answering your question based on what you have submitted. If there are other bigger fibroids, or there are multiple fibroids, quite much, all of them are 5 cm, 6 cm, 8 cm, you could have a very big uterus. But if you have just a solitary 5.5 centimeter fibroid that is not symptomatic, if you are way over 40, you are getting close to 50, you don't need to do anything. Usually the fibroids might not grow, okay? But all of this is dependent on the symptoms that you're having at this current time. Thank you.
Another question from Ramatu Ibrahim. She has a degenerative fibroid that causes pain a week to a period every month. Does that fall into this form of treatment? Can she use UFE for her symptoms?
Well, if you want to treat your fibroid, yes, you can have a fibroid embolization. It's good to actually understand what is causing your pain. Okay, maybe other things may not just be the fibroid per se. Could be the fibroid, could be other things. So if you get a doctor, really examine you, really take a proper history, get some tests, investigations done for you, he might be able to say this is exactly what is causing your pain. Okay, there are a lot of women who suffer pain during menstruation. Okay, who do not necessarily have fibroid. Dysmenorrhea I'm talking about. Okay, so if you are a candidate who usually has dysmenorrhea, okay, previously years ago, might not be related to your fibroid, but if this is a new pain that is coming because you have been diagnosed of a fibroid, yes, it could be the fibroid, and yes, you could get an embolization for a treatment. As the fibroids shrink, all of those things will go away. Over to you, Dr.
Okay. Any more questions? Okay. In the case of prolapsed fibroid into the uterine cavity, following fibroid embolization, what will be treatment? You talked about that presentation. That's a question from Uwe.
If you have a prolapsed fibroid into the cavity, into the endometrium, yes, that would be mainly a pedunculated endometrial fibroid. From experience, fibroid embolizations are not actually ideal for pedunculated fibroids. They're not actually ideal. You may actually want to get a hysteroscopy, and during the hysteroscopy, you can get offered a fibroid excision. So that fibroid can be taken out through the hysteroscopy if it is dangling into the endometrium, and such treatment options are also available.
Okay, so I think Dr. Mel, if I got correct, what she was, following the treatment, say some may fall into the cavity. So it's trying to know how do you handle or how do you treat the uterine fibroids that get into the endometrial cavity following uterine fibroid embolization.
Okay, I get that. A few of these women will expel it. You expel
Yeah.
it out from the vagina. Yes, you can see it come out. If it's small enough, it can fall out through the cervix and come out. However, if it is big and it is there and it's not coming out, you could get a hysteroscopy and you get it removed hysteroscopically. Okay, yes, so most of them will come out. Very tiny ones will fall out.
Okay. Another question from BA. What are the protocol one has to go through if you want to do fibroid embolization at Cedarcrest Hospital?
You need to visit the hospital, get a consultation with our gynecologist. Okay, we have 3 gynecologists in house. Okay, so you get a consultation with our gynecologist, get a proper history taken, get examined, get an MRI done, and once all of that is clear, I think we are good to go with an embolization. But we need to get you worked up for this procedure, examination, and an MRI. Someone did ask if we have a facility in Lagos. Yes, we do have a hospital in Lagos. Cedarcrest Lagos is in VI, 25 Kofu Abayomi Street. Over to you, Dr.
Yes, a quick concern. So thank you for the webinar. I'm asking on behalf of my sister. She had a fibroid and ovarian cyst. She had a surgery, and after 2 months, it started growing again. Since then, she has been spending a lot on herbs, injections. So just recently, she has been admitted again due to the excruciating pain and advised on another surgery. So what do you think she can do? And she hasn't even conceived, so there's infertility as well as things.
I'm sorry about your sister. I'm sorry to hear what she's going through. If you joined from the earlier part of the presentation, I did say that a lot of people spend so much on herbs and supplements that do not actually offer any evidence-based treatment for fibroid. Okay, there are known recommended treatments for fibroid. If your sister has had a surgery before, she may actually want to consider other options. A re-surgery is an option for her, but she may want to consider other options like a fibroid embolization for her treatment.
Okay. Question from Untitled. I think you touched on this though, but we still need to answer it. Aside from uterine artery embolization, are there other non-invasive treatment methods for fibroids?
Yes, there are other non-invasive treatments. One I talked about, which I said we'll be discussing in another series of our lecture, is one we call high-intensity focused ultrasound myolysis. It's actually a procedure where you use ultrasound. There are special ultrasound, not the ones you have in the clinics all around. There are special machines that emit ultrasound rays that are targeted at the fibroids, and they are used to shrink them. These are actually not ideal for very big fibroids. They're actually ideal for very small fibroids, like most of those submucosal fibroids that are small, that are causing heavy bleed. So we target them. If you're targeting an ultrasound on a very huge fibroid, for example, something that is looking like a 7-8 months pregnancy, it will be difficult to treat all of it at once. Okay, so you need various, if multiple sections for such big fibroids, and the effect is not always so optimal. But yes, ultrasound myolysis is another available non-invasive procedure. Thank you.
Okay, I think we've gone through all the questions in the
Dr. Amadi, can you ask your question? You said we jumped your question.
Okay.
Dr. Amadi, please, if you are still there, you can type it or you can ask again. I'm sure you've typed it. Maybe we jumped it. Sorry about that.
Amadi, you have been unmuted, so you can go ahead.
Okay. Can you hear me, please?
Yes, I can hear you, sir.
Okay, I was asking if you could share with us some local experiences, and then because we've had to have some few cases that presented to us after they had UFE, that subsequently had laparoscopic myomectomy. I think about 2 cases or so. So what we noticed was that some of the fibers, the degeneration was actually very low and the symptom persisted. So I just wanted to know the local experience. I know you have talked about 6 months to 1 year for significant reduction in size. Thank you.
Okay, if I'll give you a bit of a local experience, I do not have the data, so permit me. I did not prepare to come with the data, but in the last 18 months, we've had embolization, fibroid embolization done for about 15-20% patients. I can't quite quote the exact number. Of all of these patients, only one has come back to me with symptoms of cystic bleeding. Okay, only one have come back out of these 15, 18. This is a patient who actually had very huge fibroid, about, if you're a doctor, you understand what I'm saying, about 34-week size. Okay, she was actually counseled about the fact that this fibroid is big and will take time, okay, for it to actually shrink out, and all of this can happen. That's one reason why I said earlier on in my presentation that for women who have very big fibroid, they may not be ideal candidates for fibroid embolization. So most of those patients you talked about may have proceeded with an embolization with very huge fibroid masses. Usually, ideally, fibroid embolization is best for patients who are 30 weeks and below, 30 cm and below fibroid masses. Ideally, you get them fine and they are good. But once they begin to go above 30 cm, you stand a chance of having all of these poor treatment outcomes and all of that.
Okay. Okay, then Chino, so we skipped a question initially, so just go back to it quickly. What's the relationship between embolization and IVF after the treatment? I think trying to look at IVF treatment after uterine fibroid embolization.
It's a bit difficult for me to understand exactly what she needs to answer.
Dr. Melo, maybe let me give you a little clarification. Typically, patients going from IVF are usually referred to have myomectomy, like to have the fibroids taken out. So for a patient who is going for IVF, will uterine fibroid embolization be optimal, if I get the question right?
Okay, if you want to do an IVF for patients with IVF, usually your doctors doing IVF for you might be happier if the masses are all out. They may be happier if the masses are all out. If you do an embolization, mind you, you need to wait for 6 months to 1 year to get those fibroids to shrink to that point where your doctors may be happy. You may not have the time to wait for 6 months to 1 year for your fibroids to shrink away before you go do an IVF. Your doctors may not want to proceed with your IVF if your fibroids have not gotten to a level or shrunken to a level where they are happy. Okay, so they would request or they would prefer you do an open surgery. If you have all the time, you're planning your IVF 1 year later, 18 months, 24 months later, you can get an IVF, get the fibroid shrink away. You can get an embolization, get the fibroid shrink away, then go for the IVF. Otherwise, you may just want to get go straight for a myomectomy.
Eliane also wanted to know how she could check if she is fibroid free. I think that was no. Then also she said she came late, so she missed the point on the cost of the procedure. How would she know she is fibroid free? How can she check?
But to know if you're fibroid free, the most simple thing is get an ultrasound scan done. Get a pelvic ultrasound scan done. An ultrasound done by a proper trained radiologist will tell you if you have fibroids or not. Okay, so that's basic, one stop, non-invasive, easy step. 10 minutes scanning or less, you get that diagnosis done. I talked about the cost earlier on. It ranges between 1.8 and 2.2 million for the treatment.
Okay, I think another question from Eliane too. Like, I was once diagnosed with ovarian cysts. Does that make me prone to having fibroids?
Ovarian cysts are not related to fibroids. They are two different organs. So an ovarian cyst will not predispose you to fibroid. Neither will the uterine fibroid predispose you to an ovarian cyst.
Okay, I think that's the last question on the chat box.
Thank you very much, everybody, for listening. Over to you, Dr. Darcy.
So, thank all the participants for joining us and making this day a great one. So we want to advise women generally, well, if you notice any of the symptoms that have been discussed by Dr. Melo, you can come to Cedarcrest and we'll check and to let you know whether you have a fibroid and advise you what to do next. So thank you very much. Our gynecologists are always on ground to attend to you at every time. We have our office fully covered all the time by gynecologists. So we thank you for joining us and look forward to joining us in our next webinar series. We want to thank the management of Cedarcrest Hospitals for putting this webinar together. We look forward to the next one. Thank you very much.
Thank you, everyone. Bye-bye.
Stop.